Good evening. If I could please have your attention. In true Cape Town style, not only are you going to be thirsty when you come here, you're also going to be late for anything you want to. So we've got a plane that's a bit delayed. So if you could please excuse the people walking in and out throughout the proceedings. So, good evening and a very warm or very hot welcome to Cape Town and South African Drug Policy Week of 2018. Yes, thank you. So there really should be an MC to introduce the MC, but I think we're over budget on that. So I'll introduce myself. I am Nikita Hartley, and I'm a Sanput board member, and I'll be taking you through the proceedings for this evening. So without further ado, I would like to introduce Dr. Gareth Lowndes to come and do another welcome and introduction.
Always wanted to do that. Good evening, everybody, and welcome to Cape Town. I'll start with a quote. The war on drugs has failed. It has failed on the streets of the United States, where it began. It has failed hideously in the carnage of Latin America and the poppy fields of Afghanistan. It has failed in Britain, and it has failed in South Africa. End quote. Some of you, if you've read the book by Neil Woods, or Neil Woody Woods, I think he's referred to in Drug Wars, will recognize that comment, and it's from his book that was published earlier this year. Good evening and welcome to the third South African Drug Policy 2018 event. My name is Dr. Gareth Lowndes. I'm the Chief Operating Officer of TB HIV Care. Now, if you read this in front of me here, you'll notice that the theme of 2018 is policy to practice. And it seems incoherent to me that we were standing here in this exact venue 15 months ago under the banner, Let's Talk About Drugs. And in my opinion, that second SA Drugs Policy event was a huge success. And I have no doubt that tonight and this week will match that. Despite being in our infancy, and this is our third year now, the issues and challenges remain as topical, intractable, compelling, confusing, ridiculously easy, ridiculously tricky to solve. Another quote. The 1961 UN Single Convention on Narcotic Drugs is the only United Nations convention in history to use the term evil. Torture, apartheid, nuclear weapons are not described, in terms of the UN at least, as evil. Even genocide is referred to in UN documents as an odious scourge, or scourge, as I would say in my home language. End quote. The 1961 Single Convention, though, forms the basis of almost every country's drug policy. So let's match that theme this week with that statement. To help us ventilate the issues around drug policy this week, we have invited a delicious smorgasbord of tasty speakers, international commissioners, scientists, analysts, authors, academics, influencers, and of course, hand-picked local and hand-picked international experts. And they will help us unpack what it means to affect policy. This week, you are going to witness 8 plenary sessions and over 30 speakers. I would advise you to indulge in this delicious feast fully. Of course, I have to mention, as my role as Chief Operating Officer, where the money comes from. The funders for this event are the, who are they? Right to Care, Global Fund, OSF, of course, and TB HIV Care. And I understand we are also funded by the UNODC. So much obliged to the funders. The war on drugs has failed. How then, this week, can we take national and international dialogue forward to affect current and future drug policy? I think it begins tonight. We have a lineup of 5 excellent speakers who will introduce their own personal topics. And that is, I saw David Baver earlier, CDA. I saw UNODC. We have Sanak here and my colleagues from Right to Care. And of course, we round off the evening with the keynote address with Professor Michel, right? Ladies and gentlemen, welcome to Drug Policy 2018. Let the conversations begin. Thank you.
Gareth. Nobody does it better than Dr. Gareth. So I hope you enjoyed that welcome. So if we can begin the starters to this feast that we're going to have this week, I'd like to introduce our speaker from UNODC, Signe Rotberga.
Good evening. I'm very pleased to welcome everyone on behalf of UNODC, and I feel very honored for the invitation. It's a bit difficult to continue after the introductory remarks about UN conventions being a UN civil servant, but just 2 points I would like to mention. These conventions can be used also in the favor of discussion because there are good things that can be pointed. One is, if you remember about the United Nations General Assembly special session on drugs that took place a couple of years ago, as you know, there was outcome document adopted. And this outcome document, when speaking about drug policy and drug use, I think there are 2 key things that you can take and use in the policy dialogue with the government. One is, the document is clear that any intervention should be based on human rights. So that is important to remember and remind, and as the governments, the members of United Nations sign the document, so this can be shown as a reminder. The other thing that each intervention, any policy development, should be evidence-based. This is also something that is very often forgotten during these policy discussions with decision makers. So I think these are 2 key things from the recent high-level policy meetings that is worth remembering and using in the dialogue. And about the conventions, there have been a lot of discussions, but if you look at the conventions then and the goals of conventions, and it is said that the goal is to protect the health of people. And then very often, there is no need to add about the war of drugs and consequences and so on, but reminding the goal to protect health of people, of population, that's important. And then we continue from there about human rights and evidence-based, and I think this is maybe my suggestion for a constructive policy dialogue. I came here just a month ago. I'm new in the region, and as we were standing out with Professor Kazachkin and reflecting on my previous duty station, which was in Central Asia, as a newcomer, you always try to compare the regions, and during these first months I have happened to be in different meetings and engaging with members of parliament and government and civil society. And comparing with Central Asia, it is a very lively dialogue, so it's very pleasant, very promising. If I compare where I worked a couple of months ago with here, I think there is a reason for optimism. And when I was reading this introduction on the program prepared by Sean about positive results that have been achieved since the previous policy dialogue weeks, so I think that this is very really promising. I'm full of optimism and wish all the best for this week and for the future work. Thank you again.
Thank you so much, Signe. That was very inspiring. So we'll move on swiftly to our next speaker. We've got someone from CDA, David Baver, who I got in the lift.
Thank you. Good evening, everybody, and thank you for the opportunity just to say a few words. According to the mandate of the Central Drug Authority, we are required to oversee and monitor the implementation of a National Drug Master Plan after a review process which must take place every 5 years. And the current National Drug Master Plan has just been reviewed. We have now provided South Africa with a national overarching policy framework which will inform the country's response to the use of drugs in all fronts, including the broad strategy for the reduction of the distribution and supply of drugs, as well as the interdepartmental framework for the resolution of substance use disorders and the mitigation of harm related to the use of illicit and licit drugs. For the first time, we have engaged and consulted with people who use and inject drugs, and their input, together with international and local opinions, has been used to inform the development of the new National Drug Master Plan 2018 to 2022. This includes consultations with people most impacted by drugs, as well as a broad spectrum of relevant stakeholders. Draft versions of the plan have now been circulated to key experts for their opinion, and the data provided has been integrated into the new draft master plan as appropriate. We have submitted this to our Minister with a draft version, which includes policies that hold various departments accountable for their deliverables and includes harm reduction as a key component. A clear distinction is made between substance use and substance use disorder, with one of the key indicators being the measurement of the transition from substance use to substance use disorder. In recognizing there will be probably never a drug-free society, and that from almost the beginning of time, virtually every society has used drugs, we have accepted this reality, and we need to learn to live with drugs in a way that cause the least amount of harm, and perhaps some possible benefits, if this is evidence and can be shown. So we have aligned our policy in search of a return to the initial phase of freedom of choice in response to any situation. Failure to acknowledge this reality will certainly result in relapses, rather than the replacement of addictive behavior with a more socially acceptable behavior. The central feature of a human being is the expression of choice in situations of all sorts. Researchers are in a search of a way to help reprogramming automatic thinking, thoughts, emotions, and impulses generated by mental events that our minds attach to and cannot let go of: guilt, shame, fear, boredom, sadness, anger, and resentment. The attachments to the past or the future make many dysfunctional, causing a feeling of being powerless, trying to change the past or to let go of the uncertainty of the future. They are in search of programs that will allow recovery from any level of addiction and remove the pain that people inflict on themselves and on one another. Addiction recovery is not about abstinence from the drug. It is breaking free from the conditioned stimuli, as well as letting go of the toxic thoughts and emotions. We are here surrounded by both international and local experts in this field, as well as academics, policymakers, drug users, members of civil society, government officials, and politicians who can influence policy and provide solutions to reduce the harm related to drug policy, promote health, and examine critical thinking around the use of drugs with a view to developing effective policies. With the sharing of the latest evidence and the debates that will follow, this forum will be better informed on how to reinforce the human right, health, and harm reduction elements that are essential in developing effective drug policies suited to our needs. This will assist in formulating a response at an individual, for the community, national, at a regional level, moving us towards the implementation of the desired policies. I take this opportunity to congratulate the organizers and your partners of the South African Drug Policy Week 2018 for bringing together such an august assembly, and wish you well in your deliberations. I also express the willingness of the Central Drug Authority to work with you to introduce innovative programs and initiatives to deal with all matters associated with the use of drugs and addressing the symptomatic drivers. Thank you very much.
Thank you very much. That was very, very amazing. So thank you, David. So moving on, I'm not sure if we do have Sanak yet in the room. Oh, we've got Sanak over here. So thank you very much for joining us. I hope your plane wasn't too late. Over to you.
Thank you. It is an honor for the South African National AIDS Council to be part of the South Africa Drug Policy Week. The National AIDS Council brings together government, civil society, and private sector to create a collective response to HIV, TB, and STIs in South Africa. One of our key mandates at SANEC is to develop the National Strategic Plan. Key populations have been identified as a priority in the latest National Strategic Plan. Our objective for the next 5 years is to call for effective public health measures to improve outcomes for people who use drugs and urge government to implement programs that reduce the impact of the harms associated with drug use. We at the AIDS Council are acutely aware that if we wish to make any headway with our HIV epidemic, we have to implement policies and programs that are proved to work and that put people first, including people who use drugs. We need to implement health and rights-based approaches, and we need to treat people with support and care rather than punishment. Now, we all know that the world has missed the UNGAS target set in 2011 to reduce HIV transmission among people who inject drugs by 50% by 2015. We all know that insufficient coverage of harm reduction programs and policies that criminalize and marginalize people who inject drugs are failing to reduce new infections. The evidence is in place. We know what the right things to do are. The tools and strategies required to improve the health and lives of people who use drugs are well known and readily available. We look forward to the discussions at the South Africa Drug Policy Week, and we at SANEC are committed to working with partners in the country, globally, and in regional programs to see how we can improve the lives of all South Africans. Thank you.
Thank you very much. We're very glad you could make it. So we'll move on to our next speaker. We've got Mame Dean from Open Society Foundations. Maybe we can give him a round of applause.
Thank you. The applause is really not necessary. We're just the money people. We don't really do anything. No, it's a pleasure to be here again for Drug Policy Week 2018. My first time was last year for Drug Policy Week 2017, and it's really nice to see how this event is growing every single year from being a national/sub-regional event to becoming truly a continental and African event. It's one of the very few opportunities on this continent that we have to discuss drug policy, not just in South Africa again, but abroad, and how we interlink together, how we work together. And one of these moments is going to come true on Thursday when we have a discussion on cannabis growth, the new policies that are emerging on the continent, and the populations that are affected and that we need to work with. That's really all for me. I'm just looking forward to all the exciting presentations, all the discussions that we're going to have on the side. And of course, if anybody is looking for funding, I'll be sitting in the corner over there in the back behind Kunal. Just come and find me. Thank you. Take care.
Thank you very much. Payday is quite far away, so I might come and see you. So I hope you're all still enjoying yourselves. It's been an awesome night so far. And if the talks are any indication of how the rest of the week is going to go, I hope you are going to be in for a real treat. So next up, we've got Michael Marco from Right to Care.
Good evening, everybody. I'm Michael Marco, and I'm representing Right to Care. I am an MSM and someone who has lived with HIV for 20 years. And I think it's important to always acknowledge that people who are working in agencies are affected and understand their health, and it makes them understand the health of others. Right to Care is very honored to be part of SA Drug Policy Week, and it's because of Sean and TB HIV Care that has really moved this along. They deserve a huge round of applause. We would all not be here without them. I don't know if you've slept, Sean, but you look good. You look good. And I just wanted to say that Right to Care has always been in the forefront of believing that drugs and drug use should be decriminalized, and that it's a human rights issue as well as a health issue. And the health issue is something that we take very seriously. And I think what's interesting about the program and what we're going to discuss this week, and I think that the elephant in the room that has been in the room for so many years, is hepatitis C and hepatitis C treatment. And there's a lot of people here who are strong activists. And just like we were able to bring HIV treatment, low-cost HIV treatment, for people throughout South Africa, that has to be one of the missions that we carry forward. Because now that HCV treatment can be as low as $200, and it cures hepatitis C. If you had told people years ago that you could cure HIV for $200, they would be tripping over themselves. But we need to make people understand that HCV is a problem and it affects all of us, people who don't know they're affected, and by being cured is going to be a very, very important step in people's lives. And more than anything, it's going to take a groundswell of making sure that people who go in for treatment are not stigmatized. We need to change healthcare professionals in understanding that no matter who they are, no matter what they do, and knowing that the WHO says that all people, no matter if they use drugs or not, can and should be treated. And that needs to be known by every healthcare practitioner in South Africa. So I know I'm on a soapbox, but I just want to say I'm glad that we're going to be talking about it, and we're also going to be hearing some great work that's been going on, and hopefully I'll be able to be part of the dialogue because I have a lot to learn from all of you. So thank you.
Thank you very much, Michael, for those very powerful words. So now I'm very pleased to introduce my boss's boss, and the reason why I haven't made any inappropriate jokes tonight. We've got Professor Harry Hausler.
Thanks, Nikita. So good evening and welcome, everybody. It's so wonderful to see a crowded room of people from many countries and from different backgrounds talking about policy to practice. I'm just going to give a brief overview of TB HIV care and how the work that we're doing with people who use drugs fits into the broader services that TB HIV care provides. And our vision as an organization is to be a leader in empowering communities to be healthy and free of TB and HIV. The background of the organization, we started in 1929. It's a very old organization. It was called TB Care back then. And it was providing social support to TB patients and their families. But we've always believed in providing and tried to have provided services to the most marginalized communities. Initially, people in informal settlements, and more recently amongst key populations, including people who inject drugs. Our mission is to prevent diseases in the first place, TB, HIV, and other major diseases. Now, including hepatitis C, we've started a surveillance. We have some exciting results from a surveillance project that we've done. Thanks, Michael, as well, for your impassioned plea for decentralized HCV treatment. We agree with it completely. We need to diagnose and start people on the treatment that they need for TB, HIV, and other major diseases. But very crucially, we realize we have to build the capacity of individuals and other organizations to provide services and to be accountable for what we do through our operational research, monitoring and evaluation to improve comprehensive primary health care. This is a map of South Africa, and I don't know if you can see the little numbers, but 1 is Cape Town, and if you go along the coast, 12 is Nelson Mandela Bay, and then further up the coast at number 13 is eThekwini. So in each of those 3 cities, TB HIV Care directly provides services for people who inject drugs. And then close to number 21 is Tshwane, where we've worked in partnership with Out Wellbeing. We have very extensive programs. So we do work on HIV prevention in the general population, particularly targeting adolescent girls and young women. And we've started a pre-exposure prophylaxis program for them. We provide care and treatment services, initiating people on antiretroviral treatment, improving the quality of clinical care as a provincial support partner in the Eastern Cape and in 3 districts. We have community-based services and have 260 community health workers throughout the Cape Metro who provide HIV and TB prevention, education, screening, and adherence support. We've got a strong communications team, and some of you may have heard that last week was a UN high-level meeting on TB. TB HIV Care actually provides the secretariat support function for the caucus, the South African TB caucus, so getting parliamentarians involved in health issues. And in key populations, we've been providing services for sex workers, inmates in correctional services, and for people who use drugs. So our project for people who use drugs is called Step Up, and we've been providing healthcare services to the drug-using community since July of 2015. It includes the whole package of harm reduction services, including needle and syringe programs and opiate substitution treatment. We have drop-in centers in Durban and Cape Town, and one thing that we've really had a challenge with, and this is why these discussions around policy to practice are so relevant, is that we've got a politician who's interfering with service delivery in eThekwini, has actually blocked us from delivering needle and syringes since May of this year. Now we're going through a process of trying to get approval from the city to restart the services, but if we had a stronger policy framework, we could challenge her and challenge the politicians that are blocking us and hold them accountable. So it's really crucial, the discussions that we're having this week. So we've reached over a period of a year, we've reached 2,000 individual people who inject drugs, but with more than 20,000 contacts altogether. Just a couple of highlights. We're very excited about the methadone, the opiate substitution treatment program that we have. We've started 125 people on methadone. We have had challenges, particularly in Cape Town, around adherence, with only about 56% remaining adherent, but we've achieved much higher adherence in Durban with 82%, partly because of the criteria for who's started. But we have a low threshold program, and it's quite unique in South Africa for that reason. And we are also allowing people to take home doses. So this program, we're really advocating for increased access with getting methadone onto the essential drugs list. And we've really seen some very encouraging results among our people on the program, getting back into employment or to education and being reintegrated with families. I have to mention the South African Drug Policy Week from last year. It was a huge success, and I can see this one will build on the strength of that one. And it's a very important platform. So I really want to thank every single one of you for being here, for engaging. The more you engage during this week, the more beneficial the whole policy week will be for all of us. And with that, I thank you.
Thank you, Professor. So my word, time really does fly when you're having fun. It seems my job has come to an end. So if you ever need an MC, I'm looking for a side gig in the evenings. But without further ado, I would love to introduce and have the honor of introducing the heart of SA Drug Policy Week, Sean Shelley.
Okay. Good evening and welcome to SA Drug Policy Week 2018. I thought this was supposed to get easier, but it doesn't. Last night I made a momentous decision in my life. At about 11 o'clock, with a list of about 7 essential items to deliver, one due to our COO, I decided rather to go to sleep. For me, that is rather a difficult situation. But I did it. And you know what? The sky didn't fall down, the world didn't collapse. And that's because I've got really good support in TB HIV care. I'm not going to thank everybody now for that, simply because it would be kind of, I don't know, like perhaps predicting that something might go wrong. So I'd rather not do that. I'll leave it till the end of the week. Michael, thank you very much for your speech. I know that you've got an important engagement, so if you want to leave, you're more than welcome, but thank you so much for your speech. And we really appreciate you being here and making the effort to be here, despite your very tight schedule. So I really appreciate that. Thank you very much. So once again, the aim of SA Drug Policy Week is to bring the most important drug policy stakeholders into the room and have an exchange of ideas with both local and international experts. And we bring together experts from the criminal justice sector, the health sector, and of course we bring together that group that stand to lose or gain the most from these discussions, people who use drugs themselves. And that's a population that I identify with. I'm part of that key population. And we are here to disrupt some of the narratives that you hear about drug use, but also be very aware of the tremendous amount of harm that's happened in the name of drugs, but also the drug war in South Africa and to a lot of our populations. And one of our goals is, if we don't get the right people in the room, we want people to say, I should have been here. And certainly we have achieved that. I've got letters to prove that people from all corners of the globe applied to be here. We had lawyers from Nepal. We had people from countries that I haven't even heard of, quite frankly. And then we had one Australian who managed to slip in. And so I'd like to welcome Jeff Howard from the Parliament of Victoria. That's not the Victorian Parliament, because even though some of our drug laws might look Victorian, he's from the state of Victoria. So thank you very much for making the trip to come here, and we hope to learn something from you as well. Thank you. So the first SA Drug Policy Week was called Run 2016, and that happened in 2016, ahead of the UNGAS, or the United Nations General Assembly Special Session on Drugs. And there was an air of anticipation. This was the first time that the conventions were going to be challenged, and everybody was talking about these huge changes that were going to take place. And we should have listened to the keynote speaker then, Julian Buchanan, who said, I think you are naively optimistic. Of course, we said this after UNODC had released, not released a decriminalization position, but that wasn't an official paper, it was withdrawn, but then reintroduced very softly at a later stage. But essentially the message from the UNODC is this is a human rights issue. This is not a criminal justice issue. And so we thank the UNODC for continuing to support this week. We really do appreciate it. And thank you very much for being here. And I look forward to working with you as I look forward to working, or I enjoyed working with Jason when he was here. Thank you so much. So that was the first SA Drug Policy Week. And the other thing that was important was at that stage we just started seeing what harm reduction meant. We had the very early stages of the first needle and syringe programs, and we had no OST at that stage. We had a meeting, Professor Marks was there, some people from National Department of Health, a few others, to discuss the possibility of having South Africa's first opioid agonist treatment program, maintenance program, should I say. And then a series of fortuitous events. Thank you, Myrtle, and Jules, for your contribution to that in bringing Professor David Nutt to South Africa. This list of fortuitous events meant that we had one of the finest groups of speakers that you could possibly get in a drug reform setting. And that's not taking anything away from this year's speakers, obviously. But we had Ethan Nadelman, Professor David Nutt, Neil Woods, who wrote his book, Good Cop, Bad War. And I'm pleased to say that he's written a new book, which is actually even better than that book. And I've got 2 copies to give away later in the week. We'll tell you about that. Neil sends his apologies. We were hoping to get him here, but he was unable to make it due to other commitments. And then, of course, we had the great legal mind, Anand Grover, who is one of the commissioners on the Global Commission on Drug Policy, who have been very supportive of change in this country. We certainly lived up to our slogan, we need to talk about drugs, and SA Drug Policy Week 27 sparked lively debate, not only in South Africa, but regionally and globally. And so we arrive at SA Drug Policy 2018 with a very sort of different South African setting when it comes to drugs and the way in which we respond to drugs. In 2017, TB HIV Care and the Urban Future Center implemented the first low-threshold opioid substitution or opioid agonist therapy program that we'd first spoken about at the Run 2016 event. We then had the entry of the Global Fund through Right to Care as a principal recipient, and TB HIV Care and Nova Health as sub-recipients. And we saw services and awareness of harm reduction expand. Then the city of Tshwane really stepped up to the plate, because the city of Tshwane were the first city in South Africa to start funding needle and syringe programs and opioid agonist therapy. And they have over 700 people on opioid agonist therapy now. And this is a tremendous example of how we can sustain these kinds of programs and integrate them as part of our public well-being and our public health system. And I think there's a lot that we need to learn from the city of Tshwane's approach, which was implemented at a time when this kind of approach was not very popular. But people are going to be saying, they were the leaders, why aren't we doing it? And the city of eThekwini, or the municipality of eThekwini, should take an example or look at the city of Tshwane as an example, I believe. So the community-oriented substance use program in the city of Tshwane is implemented by the University of Pretoria, and that's my other boss, Professor Jannie Hugo, who's here today, and thank you very much for being here. Of course, my other boss is Professor Harry Hausler, and thank you, Harry, for your introduction again, and Gareth as well, who's also my boss. I've got a lot of bosses. And yet, I think that I answer to nobody, but of course I do. So we've seen how Tshwane can do it, and more recently we've seen the Constitutional Court decriminalize effectively the use of cannabis in private spaces. Whether or not one supports this decision, it will certainly create a much-needed momentum around the debate of drug policy and the change of the drug policy landscape locally and internationally, which is changing rapidly. However, all is not not all is progressive and evidence-based in South Africa. While the city of Tshwane were looking towards science and compassion for new ways to reduce the impact of drug use in the city of eThekwini was moving backwards. Despite engagements over a period of 36 months and with assurances that the provision of sterile injecting equipment by the Step Up project was compliant with regulation, the Deputy Mayor chose to close down the program, leaving people who inject drugs increasingly vulnerable to HIV, hepatitis, sepsis, endocarditis, and ultimately early death. There is still a reluctance to accept harm reduction services, not only among the general population, but also among some medical practitioners. This is unconscionable. The evidence is clear. We are still awaiting South Africa's new National Drug Master Plan. We know that there are some delays, and early draft versions of the document, and thank you, David, for presenting today. It was a really great presentation. As David said, early drafts of this document showed a lot of promise. Yet it remains caught within the bureaucracy of the National Department for Social Development. There are further challenges. South Africa still pays up to 30 times more for methadone than the Ukraine does, for example. 30 times more for a drug that's been around for 40 years. Methadone is still not on the essential drug list for long-term opioid agonist therapy. The latest cures for hepatitis C are not available in South Africa because to register any new medication, no matter how effective it is, it takes up to 36 months. There are continued assaults on people who use drugs. I got a report yesterday of a number of assaults in Johannesburg and the Hillbrow area of people who use drugs. We had one of our service beneficiaries slaughtered the other day just because he uses drugs for no other reason. And of course, in the Constitutional Court judgment, Judge Zondo framed the use of cannabis as a great social evil. Yet not once did he refer to the evil of the racist origins of prohibition or the evil of the disproportionate punishment for those using cannabis, particularly from the marginalized communities that we see every single day. Young children criminalized and gangsterized. We also need to consider the many people who do not have private spaces to live their lives and maybe look at the impact of that on driving the dependent use of drugs. At the South African Drug Policy Week 2018, we will examine many of these issues through the critical lens, keeping in mind the international, regional, and local data and the emerging evidence from innovative programs and the local context. We aim to focus this year on African and South African interventions and these new innovative interventions that we've got, innovative certainly for our setting. And we are no longer being passive, we are doing, and we are finding new approaches and paths towards effective drug policy and interventions that focus not only on the individual, but also the context and the systemic drivers that make the use of drugs more harmful than it need be, yet still so meaningful. For many, the risks are indeed worth it. SA Drug Policy Week would like to thank TB HIV Care, Open Societies Foundations, Right to Care, and the Global Fund for the resources and the funding that make this event possible. People have had to put up with me bugging them all the time. Right to Care, we're waiting for some paperwork to come through, and I phoned them every single day. And Ian got a number of, all the Ians got a number of emails from me on a regular basis. And some people even wondered whether it was happening because I tended to operate in a bit of a vacuum at times and then sort of dump things upon them at the last minute. So thank you for indulging me, thank you for being there, and thank you for supporting this week. SA Drug Policy Week, I believe, is going to be of great benefit to you. I trust you'll benefit from the experience and that you'll think critically about drug policy and our global, regional, national, and most importantly, our personal responses to drugs and the people who use them. And it now gives me great pleasure to introduce our first keynote speaker. Last year, we closed with the commissioner from the Global Commission on Drug Policy, and this year, we'll start with one. This will be the third commissioner from the Global Commission I've had the privilege of introducing to a South African audience. 3 years ago, it was Madame Ruth Dreyfus, the former president of Switzerland, and a great advocate for drug policy reform. And she spoke to an audience about opioid substitution therapy in a South Africa where there was no opioid substitution therapy. Last year we had Commissioner Anant Grover, who spoke of the legal arguments that he believed would secure a constitutional court decision that would decriminalize the use of cannabis in private space. He was correct. And the court has ruled that the use of cannabis in private space cannot be made a criminal act. And indeed, we now have opioid substitution therapy in the country. So, following from these two events, I'm looking forward to what Commissioner Michael Kazashkin has to say today, because there seems to be a pattern. A commissioner from the Global Commission says it, and it manifests. If this proves to be true, I would not be surprised. Each of the commissioners of the Global Commission on Drug Policy is a person that has earned respect, a person whom global leaders and policymakers will listen to and take seriously. And Professor Kazachkin is no exception. I first heard him speak at Wilton Park in the UK at a hepatitis C meeting, and I said to myself, I would like Michel to be at SA Drug Policy Week, because he speaks with an authority that means that he doesn't have to compromise what he's saying at all, with a calmness and with an absolute assuredness that is supported by ample data. And so I'm really looking forward to this talk. These achievements of Michel's, which are huge, you can go and look on his website. It's just pages of things that he's achieved. I wouldn't possibly be able to do it justice. But what these achievements have meant, that it's led him here today to share his wealth of knowledge with us. And if we can just take on a small portion of that knowledge, we would have a much better South Africa. A South Africa where our youth have hope, have opportunity, and will find that the use of drugs is not the most important thing in their life. And so it gives me great pleasure to introduce Commissioner Michel Kazachkin.
Thanks, Thank you. Good evening. Thanks very much, Sean, for this introduction. And the last document the Global Commission released was a call for ending prohibition and moving towards legal regulation. So let's hope that this is the next step in South Africa. It may take a little time, but we'll get there. So it's a pleasure for me to be back in South Africa. Thank you for the invitation, and I look forward very much to meeting all of you in the coming days. It's also a pleasure, I must say, to be here in a meeting co-organized by OSF. I'm a member of an advisory board to the OSF Global Drug Policy and Public Health Programs, and to be here as a former executive director of the Global Fund in an event co-sponsored by the Global Fund. But the capacity in which I'll be speaking is being a member of this Global Commission on Drug Policy, which, as you can see on this slide, is a group of 22 people, leaders, formal leaders, that have come together to advocate for evidence-based, human rights and public health-oriented drug policy internationally and across the world. We are 22 members. We lost a few months ago, 2 months ago, a prominent member of the Commission, and that is Kofi Annan. And I would like to dedicate these remarks today to the memory of Kofi Annan. Kofi has been a champion of peace. He has been a champion for drug policy reform, a very active member of our community and of our commission. Of course, Kofi has been the inspiring father of the Global Fund. And to me, he has been an extraordinary friend and mentor throughout the years. So, yeah. So let me start with a quote from Kofi that many of you would have heard, I'm sure, and he has said, "Drugs may have harmed many people, but poor government drug policies have harmed many more." And that's the starting point for the work of the Commission. So let's go back to the preamble of the 1961 Single Convention, and that preamble says that the aim of the convention is the health and welfare of mankind. And as Signe said, this must be our sort of guiding star. But the reality, of course, is that we haven't achieved what was expected in that preamble. Rather, the policies that have been running for 40, 50 years now not only have failed to achieve the goal of providing controlled medicines to people in need for pain management, for palliative care, not only have failed to take care of people who use drugs, their health, their rights, but they've been harmful. And so the first thing the Commission did, and what I'd like to do tonight, is actually take you through a 5-year itinerary. The Commission is 5.5 years old, and take you through an itinerary and show you how our thinking, our collective thinking in that Commission has been evolving from our first report, 2011, that said, break the taboo, let's open the debate, to our report released 2 weeks ago in Mexico City, which is end prohibition and move to legal regulation. Stop prohibition. Move to legal regulation, just as we regulate everything, every substance, every behavior that is of potential risk. We do not prohibit alcohol, tobacco, food preservatives, driving cars, whatever. We regulate what is risky. And this is the government's responsibility. We were not, to be honest, as strong on saying end prohibition 5 years ago. And it's this sort of itinerary that I'd like to depict to you and have you join now. 5 years ago, we started, as I said, with a first call on break the taboo. And that meant open the debate, but an honest debate, not the sort of debate we have in the field of drugs, which is full of a priori, full of ideological, preconceived opinions, an honest debate based on facts and based on evidence. It was also a call for acknowledging the failure of the war on drugs and the failure of policies that for 40 years have been based on prohibition law enforcement. These policies have failed. I think it's worth repeating it, and let me go briefly through those failures. First, they failed by their own measure. They were, if you look at the, not so much the 1961, but the two later conventions, particularly the 1988, which was the most punitive. Or if you look at the ridiculous call for a world without drugs of the 2009 UN High-Level Summit. If you think of these aims, let's eradicate the market, let's have a world without drugs, obviously the world has failed. More drugs are produced, more drugs are available, they are cheaper, of higher purity, more heroin has been produced than ever last year. Cocaine has increased tremendously, and of course, every week, new synthetic drugs are coming on the market. More people are also dependent on drugs across the globe, and this is something that is increasing in Africa. I'll come back to that in a minute. So the punitive approaches have really failed on their goals to extinguish the market. But not only have they failed, but they have generated what UNODC, Signe, sorry for being slightly ironic here, has called unintended consequences. And those unintended consequences have been, firstly, generating a huge criminal black market. And that black market, as you know, fuels violence, crime, corruption, narco-states. That is a market that is currently estimated to be worth $360 billion per year. Big business. It has fueled, these policies have fueled mass over-incarceration across the globe. And I'll come back to that as well. Significant human rights abuses on a daily basis, from death penalty, which is unjustified from a legal perspective, to extrajudicial killings, as what is happening in the Philippines now, to everyday police brutality, or in many countries in Asia, still inhumane compulsory drug treatment. And finally, and because I come from the health and from the AIDS world, it has fueled an AIDS epidemic, a hepatitis epidemic. It puts people at high risk for TB, and in many parts of the world for MDR-TB as a public health threat and as a safety threat. The hepatitis C and the AIDS epidemic we've seen across the world, but we've also seen how, with harm reduction, the problem can be solved. In my country, France, in Western Europe, there's no more new HIV infection among people who inject drugs. Less than 1% of the new HIV infections are among people who use drugs. The problem is solved, just as vertical transmission is now fully prevented with antiretroviral preventative treatment. However, in Eastern Europe, where Signe and I have met many times, let's say in the Russian Federation, there's 120,000 new cases of HIV infections reported every year, and still 50% of those are among people who use drugs. So, people who inject drugs and harm reduction, no more HIV infections, and probably, if no more, but significantly less hepatitis C infections. There's new data showing that, of course, needle programs, but also OST by itself significantly reduce the risk of contracting HIV for people who, hepatitis C for people who inject drugs. And on the other side, countries that refuse to move to harm reduction and health-oriented policies have huge epidemics ongoing. Now, Kofi Annan said a year and a half ago at a WHO side event that we were organizing, "What worries me now is the African continent. The continent has become a hub for trafficking, and the domestic consumption is on the rise. Yet, very few countries have now prevention and treatment services in place and available. Very few countries." So I was really pleased to hear the progress here in South Africa and meet with colleagues from the Tshwane municipality. This is remarkable progress, and I hope that South Africa will become really a leader on the continent. I have no time to go into the detail, but I'll be very much ready and happy to speak with all those interested about the work of a sister or niece of our Global Commission, which is the Commission on Drugs in West Africa that published a report 3 years ago that was led by Kofi Annan and former president of Nigeria, Obasanjo. And that commission now published a new report called a model drug law for Africa, actually for West Africa. I have left a few copies of that document. It's on the web, but I think it's something that South Africa should look at, even if the specificities of the epidemic is slightly different. So AIDS, hepatitis C, and tuberculosis. People do not associate TB with people who inject drugs. But people who inject drugs are 6 to 8 times at higher risk than the general population of contracting TB. And if you are a person living in Eastern Europe who inject drugs and who has been incarcerated, your risk of contracting TB is 28 times that of the general population. Because actually TB among people who use drugs is very closely associated with incarceration. A recent study in Ukraine has shown that 75% of the TB cases among people who use drugs are in fact associated with incarceration. And because people who have been incarcerated at one point end up being released, and because the release from prison is often not well prepared with a good relay in the community, incarceration of people who use drugs, which, by the way, is often incarceration of people just for simple possession, for at least 50% of those incarcerations. That accounts for 10% of the overall TB cases in Ukraine, in the country. So it's a public health issue. Absurd incarceration leads to a public health threat. But AIDS, Hep C, and TB are not the only health unintended consequences or poor policies. Another one, and that is to me a key argument for legalizing and for regulating drugs, is that when you buy on the street, you don't know what you buy. And more often, things you buy are adulterated drugs. Whereas if you were to buy in a shop or wherever, or be delivered on prescription, something that is regulated by the government, you would know what you buy. And we've seen with the opioid overdose deaths in Canada particularly, that are mostly due to heroin that is cut with fentanyl, the tragic consequences of not knowing what you're buying on the street. Another, of course, unintended consequence is that the international drug control regime, in the way it has interpreted the conventions, by being repressive, has really put a set of legal and policy obstacles to the provision of opiates for people who actually need them. And the global picture by WHO is that somewhere around 80% of the people worldwide who need opiates for management of pain or palliative care do not access the medicines. So this is why throughout the years and after our first call on let's open the debate, let's break the taboo, we've published a number of reports on how prohibition fuels the HIV epidemic, how prohibition fuels the hepatitis C epidemic, on how the international drug control regime restricts access to opioid medicines, controlled medicines for people in need, on how, on the opioid crisis in the US, but I won't go into all of this. I will jump to the 2016 UNGAS, which Sean mentioned. We also were sort of waiting for a big moment in drug policy that did not happen, although some progress was made in the language. But as we were preparing for that, we came with a report which advocated for 5 key pathways for drug policy reform, 5 pathways for drug policies that work, as we called it. This is still our Bible somehow, and our guiding principles. I'll go into a little more detail on some of these. First, put people's health and safety first. Second, ensure access to essential medicines and pain control. That is, access to opiates for people in need for the management of pain, but also access to methadone, of course, and buprenorphine for harm reduction, because both of these are on the WHO list of essential medicines. 3, end the criminalization and incarceration of people who use drugs. 4, refocus enforcement responses to drug trafficking and organized crime. Stop having the police spend precious human and financial resources in catching every week the same people on the street and arresting people for drug simple possession with no intention to sell or that do no harm to others. In my country, France, 150,000 people are arrested every year for cannabis. 150,000 arrests. France is one of the worst countries. As a mirror image, it's the country in Western Europe that has the highest consumption of cannabis. I think one goes with the other. The more you repress somehow, and out of these 150,000 arrests, whereas it is a criminal offense in the law, in the books, only 100 people end up actually incarcerated. So it means that it's just a ridiculous effort. The policeman arrests people, brings it to court, and then nothing happens. People are released. So can you imagine? And when we are under, terrorist threats, as you've heard, almost every day, and complain about not having enough police. So refocus precious resources, human and financial, towards drug traffickers, towards money laundering. And 5, regulate drug markets to put governments back in control. Take the market from the criminal market to government control over the market. So let me just expand a bit on this. I spoke on health. I'd like to spend a few minutes on decriminalization. Of course, we need to end criminalization and incarceration of people who use drugs, acknowledging that this has led to a huge wave, that I mentioned before, of prison overcrowding and over-incarceration across the globe. In the US, in the Russian Federation, over 50% of the people who are incarcerated because of a drug offense. And in many cases, this is a minor drug offense. This is actually simple possession with no harm to others. And in the US and in a number of other countries. But this has had a devastating impact on communities of color. 43% of the people incarcerated for drug offenses in the US are Afro-Americans, whereas Afro-Americans represent 13% of the American population. It has also had an extraordinarily tragic negative impact on the women. 70% of the women incarcerated in Latin America are incarcerated because of a drug offense. 2 weeks ago in Mexico with colleagues from the Drug Commission, I visited a women's prison in Mexico City, and I met with 2 women, now 30, 35, who were young women left alone with their children, husband left the home, no economic resource, and at one point they agreed to be a mule, a courier. One was sentenced to 17 years, the other one to 25 years. We met them, they've been in prison, incarcerated for already 12 and 15 years. Just unthinkable in human policies. And then just think of what is a criminal record for someone. Having a criminal record is really a huge price to pay when it comes then to employment, education, housing, getting a loan, driving a car, and young people's lives can be just ruined. And here let me quote Kofi Annan again. Quote, "A criminal record for a young person for a minor drug offense can be a far greater threat to their well-being than occasional drug use." Yeah? So let's keep these words with us. And all of what I've been saying provides, I think, a very strong background for us all to advocate for decriminalizing drugs and drug possession for personal use. But it's not only because of this that we advocate for decriminalization. We also advocate for decriminalization because we think that criminalizing drug possession for personal use is interfering with a fundamental human right, which is the right to privacy. This is a fundamental right enshrined in the 1948 Declaration of Human Rights. Privacy is the cornerstone of human dignity and the state and of human autonomy. And the state can only interfere with privacy if it is for a legitimate aim, if it is proportionate, and if it is necessary. Now, in our view, penalizing people who possess drugs for personal use and do no harm to others, this is neither proportional nor necessary, nor, of course, legitimate in any way. In addition to that, to us, in some way, criminalizing or continuing criminalizing possession of illicit drugs is somewhere undermines the rule of law, because the law is that this is a criminal offense. And every year, 285 million people across the world actually use drugs. And if we keep hypocrite attitudes where we say this is the law and let things and accept that things happen, and we of course have to accept that things happen, and there are many good things also about taking drugs for a number of people, then clearly we're undermining the rule of law, and that leads this misinterpretation. The fact that the French policemen, as I said, have to keep arresting people and then they immediately release them, leads to corruption, leads to misunderstanding by the judges, and we end up again with a law that is not respected. So for all of these reasons, the Commission came with strong recommendations, and there are 3 recommendations. Abolish the death penalty for all drug offenses. Second, end all penalties. And our view is that it's not only decriminalizing, that is not only removing drug possession for personal use from the criminal justice field, it's remove all penalties, both criminal and civil, for drug possession for personal use and the cultivation of drugs for personal consumption. So we just cannot see, on the basis that we believe this is a human right to privacy, we just cannot see why should be punished at all. And we also advocate for the fact that states should implement alternatives to punishment, such as diversion away from the criminal justice for all low-level, non-violent actors of the drug trade, such as those engaging in social supply, drug couriers, user-dealer, and cultivators of illicit drugs. Those that are driven often by poverty and marginalization in society have no other opportunity than go into the drug business. And if there is something that we could hope, Sean, would be, would happen not too long from now in the South Africa, I think it's ending penalties more than beyond decriminalizing, decriminalizing all drugs, and looking at alternatives to criminal punishment for low-level actors. Let's hope that by next Drug Policy Week 2019, this is what happens. And the last recommendation was on regulation and ending prohibition. We're saying legal regulation, move to legal regulation. We're not saying move to legalization, because legalization is often misunderstood as, let's say, uncontrolled liberalization somehow. That's not what regulation is. Regulation we understand as responsible risk management by governments. Just as I said earlier, as you manage everything that is risky. And that is tobacco, that is alcohol. And if you look at some of the global burden of disease studies that were published in the Lancet in September, despite the fact that the burden of tobacco and alcohol-related harm remain huge, the world is making progress. But the world is not making progress by prohibiting alcohol or tobacco. Although alcohol kills 3 million people every year, and tobacco will kill 50% of smokers. We are regulating tobacco, alcohol, and that's how we're making progress. And I'm sure many of you will have witnessed in South Africa progress over the years with tobacco. We're regulating pesticides, we're regulating food preservatives, we're regulating radioisotopes, we're regulating potentially dangerous medicines that, by the way, overlap, of course, with the now illicit drugs. So that is the reasonable way to handle, not prohibiting. And of course, the US have done the experiment with alcohol prohibition. That has led to a huge criminal market, just as we have witnessed with illicit drugs. So why is this exception remaining? And this is why I think what we, all of us, have now to try and change in this country and everywhere across the world. Because too many people have died, too many people have suffered, too many people are suffering today of the harms of prohibition. So it's time to rethink, fundamentally rethink the way we look at drugs and move out of prohibition. I won't go into details here. Steve Rawls will give a plenary on regulation tomorrow, I understand. But regulating drugs, as I'm sure he will discuss, is about every step regulating production, so you know what you're actually producing and you know what's the content of the drug that will come on the market. It's about regulating price, potency, packaging, availability on the market, be it in an unlicensed shop, let's say for cannabis, as it probably will be across the world soon, or in licensed premises, or in specialized pharmacies, or for the most dangerous drugs, let's say on medical prescription. And because, let's be clear, when we say currently prohibited drugs should be regulated, it's about all drugs, and heroin-assisted substitution therapy programs in Switzerland, for example, or in the UK, are to me a model of what could be a medical prescription of heroin for some people. So, but anyway, the precise delineation of how countries will move to regulation will, of course, depend on the drugs, but also on the social, political environment in countries and cultural environment on countries. I believe this will be an incremental process, but steps are being taken. Of course, legal regulation of marijuana for recreational use in Uruguay, then in a number of US states by referendum. Very interestingly, states have gone against the international conventions. And the federal government, the Obama administration, and now even the Trump administration, do not say anything. Some of you have heard Ambassador Brownfield from the US a few years ago when Uruguay announced that it will legalize cannabis, saying this is against the convention, we will fight it. Now that referenda have brought cannabis regulation to many US states, Ambassador Brownfield has been saying, well, there are flexibilities within the conventions that we should consider. I was very interested in the experiments that have started in New Zealand with NPS, with synthetic drugs, where New Zealand said, okay, if you wish to produce and sell a synthetic drug, bring us a dossier, just as you would submit a new medicine to a national agency with the content, the way it's produced, the dosage, what you know about the effects, and we then may allow that product to be sold in adult shops. And as this started being put in place, the number of circulating synthetic drugs in New Zealand decreased drastically because people went for buying drugs that they would know what they are, instead of buying on the streets potentially adulterated drugs. So steps are being taken in that direction. So that's where we have come to in these 5 years of our itinerary at the Global Commission. And now we are very clear, and I would like to be very clear tonight. The ultimate goal of all our efforts in drug policy and drug policy reform should be ending prohibition. If we continue with prohibition, we will continue with law enforcement repressive approaches, and that will mean continuous failure and continuous harm. Ending prohibition is, to me, an unambiguous endpoint of where we should go. And so we need, my call tonight, I'm realistic. That will not happen from one day to next. But my call is, again, open the debate. Open the debate and look for allies in that debate. And we will have in the drug policy movement allies, of course, in the health sector, because of the health harms, and in the human rights sector. And I'd like to close with a few words on human rights, because Sean, you rightly said that this is at the very center of everything we need to do. And we will never achieve anything if we do not put human rights at the forefront of everything we do in drug policy reform. And these human rights have been enshrined in the 1948 Declaration on Human Rights and in a number of other conventions and treaties in the United Nations. Let me remind you, the right to health and to decent care, the right to freedom from discrimination, the right to equality before the law, the right to privacy, the right to benefit from the advances of science. These are all human rights. So let's remember there are also the rights of people who use drugs. And we will not win the fight against HIV/AIDS, hepatitis, TB, stigma, discrimination, marginalization, incarceration, if we do not win this fight for those rights at the very beginning. Thank you.
Thank you, Michelle. We're about to get to the food and the drugs, the alcohol, the acceptable drugs. Thank you very much for your message. What is different perhaps this year is that we've got a much broader participation. And so for a lot of people, these might seem like radical messages, crazy messages, but they are data-based messages. And that's the most important thing. We have to look at the data. We can't let our own personal beliefs influence the landscape when it has such devastating consequences. And I'm always reminded of a saying which I think is particularly pertinent for South Africa, is that current international drug policy is the perpetuation of the colonialism through the myth of international consensus on drugs. And we've really got to think about that critically with our history here. So there are just a couple of things I want to mention. For those of you who need, harm reduction packs are available in the office. We also would like to say that there is an app for this, or a website, is that I think is correct to say, Yuri, a website available. So you'll get an email which from a thing called Huddle. Look in your what they call it, spam folders. If you can't find it there, it will come to you, or speak to somebody, give us your email address, and you'll get it, and you can access photographs, videos, interviews, and the like from the day that you've just listened to. And yeah, we hope that you will spend some time thinking critically about these issues and interact with other people from different fields and people with opposing views to you, because that's the only way we're going to get to understand each other. So thank you very much for being here this evening. We look forward to seeing you tomorrow when our second keynote starts at 10 o'clock. So remember, 10 o'clock in the morning, please be here on time. And each day we'll have some giveaways and some other exciting things happening. So enjoy the rest of the evening, go and have a drink and go and have some dinner. More importantly, eat first before you drink. Good harm reduction.